Hi, everyone. So I think this is the 30th time I've done this presentation so far. And I think for some of you, it's the 29th time you've seen it. So you're probably used to everything I'm about to say. The last time I was up here, I started with a straw poll of the room to try and figure out if you guys preferred the term patient or resident, and it was completely useless. You guys split down the middle, and it didn't help me at all. So we'll try another one today. How many of you feel like your providers, your buildings have been doing a good amount of training for PDPM up to this point? How many of you feel like you're getting pretty well prepared? Okay. How many of you feel like your buildings, they've just kind of started on PDPM, they really haven't done very much? Anyone? Okay. How many of you were just walking by the doors, figured this sounded interesting? No? Okay. That'd be kind of cool if someone just walked in and was like, I want to know. Here's another weird question that'll probably scare some of you. It's certainly going to hit me a little bit. How many days until PDPM? Anyone know? 47 and a few hours. 47, what is it, 21 hours? Something like that? I was saying, you actually have it very specifically down to like the minute and the second. So it's about 47 days between now and when PDPM comes online. So what we're going to talk about today is to kind of go over that broad overview of PDPM that I'm sure many of you are familiar with. I think it's always helpful to get a lot of things reiterated and to hear it again. Talking about what is changing as a result of the new payment system, and then also to remind once again the various things that are not changing under the new payment system. So we'll again talk about some of the key aspects of the new model. Talk about some of the things that are changing or are not, and then also to talk about the transition, because that's also something that I think a lot of people have had questions about in terms of the transition from RUG-4 to PDPM. Acronyms, we love our acronyms, you guys know this, and so they're all defined here, so I'm just going to skip through these. So, talking about PDPM, why are we here? You've heard me say this before, so I'm going to try not to go too soapboxy with you today. But the reasons that we're here have to do with some of the underlying issues inherent within the existing payment system, that is RUG-4. And they break into two different types. The first being that the therapy payments under the existing payment model are entirely driven by service utilization, and we see the impact of that. We see that people, the very high percentage of people, sometimes even 90% of patients within a facility, getting exactly 720 to 725 minutes worth of therapy. So we can see the impact of the therapy payment model under the current system and how it impacts on patient care. The other one that we talk about that's not as often discussed is how people are classified in terms of nursing. And you could have two patients that have widely different nursing characteristics, and yet we pay exactly the same amount for their nursing care because of how the system pays. It funnels everything down into a single group, and we'll see a little bit more about that in just a little bit. We enter PDPM, and we believe that PDPM is an improvement over the existing system for a variety of reasons. The first, that it improves payment accuracy and appropriateness by actually focusing on the patient. Okay? It's not about what you do for the patient, it's about the actual patient, because that's where the focus should be. It's an entirely patient-driven model, okay, in the sense that it is driven by the patient's own characteristics. It significantly reduces administrative burden on providers. Terry had already talked about the reduction in terms of number of assessments that we see in AO 310B. I know many of you want to still complete the 14, 30, 60, 90-day assessments, and I know you all love COTs, EOTs, SOTs. But under the new system, it's a lot less burden for all of you. And it also reallocates SNF payments to currently underserved beneficiaries, by which we mean that right now, the main patients that are getting in the door are those that have high therapy needs, the ones that can tolerate 720 to 725 minutes worth of therapy. The ones who are potentially not getting in the door are those patients that have more clinically complex needs, that have high NTA costs. Those are the ones that we wanted to make sure that PDPM targets by shifting the money. Okay, there's no additional money going into the SNF benefit, I apologize. So it's about a $36 billion a year benefit. And what we do with that $36 billion is shift it around and hopefully introduce new patients into the SNF that may have had trouble getting in the door due to the inherent incentives in the current payment system. Talking a little bit about the current system versus the new system, RUG-4 consists of two case mix adjusted components. There's a therapy component, which again, driven by the amount of therapy that person receives. And then a nursing component, and I've already mentioned this, but again, if you have two patients that say both fall into the group Rehab Ultra Level B, the nursing component, the nursing case mix weight that we use for those patients, they're all in RUB, is exactly the same, which means that if you have 5 different patients that all have widely different nursing criteria, or widely different nursing characteristics, if they're all in RUB, we pay exactly the same nursing cost, despite the differences between them. Okay, and that's an inherent inaccuracy in our payment model, that it doesn't address specifically the nursing costs for that patient. RUG 4 also uses a constant per diem rate, which is to say that we pay a rate for each day of the stay, and that's something that's statutory. We couldn't change it if we wanted to. Call your congressman. And so it's a constant per diem rate, which means that if it's day 1, 50, or 100, we pay exactly the same per diem rate for every one of those days. And what we found in our data when we were doing the analysis for this was that that's not how costs are incurred. Okay, costs are incurred in a very different way. Specifically, NTA costs are incurred in a very different way than looking at it from the perspective of just paying the same rate every single day. RUG 4 looks like this. You have those 2 components. Okay, again, you have a therapy rate. Okay, the base rate is there. It gets multiplied by a case mix weight. The case mix weight is intended to reflect relative differences in terms of costliness, in terms of resource utilization. So you have a therapy rate, that it gets added to a nursing rate, the non-case mix rate, you get your total per diem rate. PDPM takes a more explosive view of this and breaks out those 2 components into their 5 constituent components, by which I mean that the therapy component under RUG 4 gets broken into its constituent disciplines, which are PT, OT, and speech, and the nursing component gets split into its 2 constituent components, which are the nursing and the NTAs, okay, or non-therapy ancillaries. And I'm sure you've heard me say this before, but anytime I mention NTAs or non-therapy ancillaries, just think drugs, because drugs are the main cost component behind NTAs. PDPM also introduces a variable per diem payment. I always have struggle with using the term variable, I don't know why. But it introduces a variable per diem payment, which is to say that the rate that we pay per day is not the same rate on each day of the stay. It changes over time. And between the PT, OT, and NTA components, the schedule for how we adjust that payment over time is different. Okay, the PT and OT components follow more of a standard sort of slow trajectory in terms of decline. The NTA component is more front-loaded, where there's a very high payment in the beginning and then becomes a more consistent rate over for the rest of the stay. But again, this is to ensure that the payments are being better targeted to when those costs are being incurred. So it's not just simply a constant per diem rate that pays the same amount across time, but instead puts the payments where they're most properly, or where they're being incurred. This is what PDPM looks like. It looks very complicated from the sense that there are more boxes than the picture I showed for RUG 4, but they all follow a very similar algorithm. For PT, there's a base rate, or for all of them, there's a base rate, and then there's a CMI, a case mix weight, and then for those 3 that I mentioned, the PT, OT, and NTA components, there is the variable per diem adjustment factor. Okay, and so you just multiply those across, and you get the component rate. Add them all together with the non-case mix rate, you get your entire per diem rate. There is a mention here of the 18% nursing adjustment factor for patients with HIV and AIDS. That is something that I'll talk about a little bit later in terms of how we pay for this specific patient population. But again, for each one of these, you get the component rate, add all the component rates together with the non-case mix rate, you get your total per diem rate. Now the current model, as I mentioned before, and I always use this term of a funnel, because really what the current model does is it takes all the various things about a person, okay, all of their therapy needs, their nursing needs, their NTA needs, takes all those things together and funnels them down into a single RUG 4 group. Okay, and there are 66 total groups, which would imply that there are 66 total types of individuals within a SNF. And I think we all know that that's not the case. Okay, so you can't take everything about a patient and funnel it all down to a single group. PDPM, on the other hand, again, takes that more explosive view of a patient, takes a more patient-driven view of a patient, which is to say that we look at the patient and we look at each one of their needs independently. And we control for each of their needs independently, and then pay for each of those needs independently. So we look at their PT needs, and we have specific criteria for how we classify them for PT and OT. We look at their SLP needs and classify them for their SLP costs in a very different way than we classify them for PT and OT. Now the impact of this is that as opposed to RUG 4, which would again put everyone down into a single RUG 4 group, PDPM is able to take a much more nuanced approach to payment, which is to say that you have, let's say, patient A on the left that has higher NTA and higher SLP needs than patient B. okay, or patient B that has higher PT and nursing needs. Whereas RUG-4 would pay the exact same rate for these two people, okay, probably in RU. PDPM is able to, again, take a more nuanced approach and pay for these two patients very differently, okay? Now, we're going to go through an example of this just to kind of see how patients get classified under PDPM and compare it to RUG-4. So we have these two patients that are very cleverly named patient A and patient B. They have various characteristics that we have listed out here. Okay, the first four criteria or first four characteristics that are listed here, rehab received, therapy minutes, extensive services, and ADL score, that's all I need to know what we're paying for over 90% of the days that we pay for currently under Part A. Now, with those four categories, there is very little about the actual patient. Okay, you don't almost really have to look at the patient to know those four things. For ADL score, you do. But for therapy, when we look at the data and we see that, for some facilities, we see 90, even 95 or more % of their days are paid for using a therapy rug where the person is receiving exactly the same number of minutes across all of their patients. What that's telling me is that they're not looking at their patients either in terms of the specific characteristics and needs that that patient has. So here, those first four characteristics are all that I need to know to classify most people under RUG-4. The rest of the characteristics that are here are those that become more relevant under PDPM. You can see a wide variety of different characteristics, such as their clinical category, which is predicated on their primary diagnosis. The main reason that they're there is now going to matter in terms of their payment classification. Whether they have cognitive impairments, swallowing disorders, all kinds of different characteristics that now are relevant under PDPM in terms of payment. And we see that they have different types of characteristics for each of them. Now, under RUG-4, because when we looked at those four characteristics, we saw that each of them received 730 minutes worth of therapy, which, again, is not uncommon that we would see two patients, or even more than that, receiving exactly the same amount of therapy. Now, because of how RUG-4 pays, those two patients are going to be falling into the exact same group. They received at least 720 minutes worth of therapy, there were no extensive services, and due to their ADL score, they fall into group RUB. Okay, and so both of those patients, despite all of the wide differences between them, okay, on the prior slide, all of the differences that were below those first four characteristics, none of those matter in terms of payment under RUG-4, and they both fall into the exact same payment group, which means we pay you the exact same rate for each of them. Now, PDPM, again, takes a very different approach to this, and we'll look at each of the components separately. So for PT and OT, the two things that matter are the clinical category and their functional score. The clinical category, again, is an answer to the question, what is the main reason that that person is in your building? That's it. That is the fundamental question that we're asking in terms of their clinical category. That leads to a diagnosis. That diagnosis maps to a clinical category, and that clinical category then falls into one of these four consolidated clinical category buckets for the PT and OT component. So here, because patient A is classified as acute neurologic with a functional score of 10, we see that they fall into the non-orthopedic surgery and acute neurologic group, and then the 10 to 23 functional score bin. The functional score is calculated very similar to the way we do it under RUG-4. The main difference here is that as opposed to using section G, we are now using section GG to actually align us with the direction that pretty much all of the PAC systems have been going. Patient B, on the other hand, had a major joint replacement, and it has a functional score of 10, and so therefore they are put into that first clinical category bucket and then the 10 to 23 functional score bin. Already, just from this one, or from these two components, we are already creating a difference in terms of how we pay for these two patients as compared to RUG-4. The SLP component uses very different criteria in terms of how we assign a payment classification. Here, what matters is that first set of tiered criteria, which is the presence of an acute neurologic condition, an SLP-related comorbidity, or a cognitive impairment. And then a patient would either have none of those three things, they'd have any one of them, any two, or all three. Okay, and if they have, and whichever of those they are, that's where they fall into. The second tier of criteria are if they are on a mechanically altered diet or had a swallowing disorder. Okay, again, very different criteria than what we're seeing under RUG-4. At no point here are we mentioning how much therapy that person got or what the therapy minutes were. It's entirely driven by the characteristics of that patient. So patient A on the left has an acute neurologic condition, a moderate cognitive impairment, and is on a mechanically altered diet. So for that first one, it was acute neurologic and moderate cognitive impairment, so that's the NE2, and they were on a mechanically altered diet, so they get the either. Patient B that's depicted on the right is classified as non-neurologic, which is to say they didn't have an acute neurologic condition. There was no other sort of speech-related issues, and so therefore they fall into the none and neither category. So again, where RUG-4 would put these two into the same group, PDPM is starting to separate and provide for a much more nuanced classification and payment. The NTA component operates in a very different way than I think any of the other components do. Because when we were developing this system and trying to figure out how we wanted to capture the added costs associated with NTAs, we looked at a number of different systems and saw how it was done in other places. And some systems utilize a way of looking at the most expensive comorbidity that a person has, okay, most expensive condition that a person has. And that works in various ways, okay, in terms of ensuring that you're capturing the costs associated with that most expensive condition. But what it doesn't do is take account of the fact that there is an additive effect if a person has multiple comorbidities. So we also looked at systems in which it would just look at how many comorbidities a person has and assign a payment classification based on the number of conditions that a person had. And that, again, takes account of the fact that there is an additive effect between comorbidities, but what it doesn't account for is the fact that each of those comorbidities does not cost the same amount. So we had to find a way to try and balance those two conditions. And what we found was, and what we developed as a result of that, was what we refer to as the NTA comorbidity score. There's about 50, I think there are 50 conditions that are listed in our NTA table. Each of them has different, or some of them have different points associated with them. Okay, so for example here, IV medication has a score of 5, diabetes has a score of 2, and chronic pancreatitis has a score of 1. And each of those scores is intended to reflect its relative costliness as compared to the others. So more expensive conditions have more points, less expensive conditions have less points. You take all the conditions that a person has, along with the associated point values for each of them, you add them together, you get their total NTA comorbidity score, and then they fall into one of these different bins. So here, patient A, due to the IV medication and diabetes, they have a total of 7 points, so they fall into the 6 to 8 bin. Patient B only had chronic pancreatitis, I say only, and that means they have a score of 1, and therefore they fall into the 1 to 2 bin. The nursing component, okay, as we're talking about all these things, and it actually sort of fits within the overarching theme of this presentation in terms of talking about things that are changing and what is not. We've been talking about the various components that have changed, and we now come to the one that actually hasn't changed that much. Okay, the nursing component under PDPM is functionally the same in many ways as the nursing component under RUG-4. Okay, the various criteria that we use to classify a patient under the nursing component under RUG-4 are pretty much the same that we use under PDPM. The main difference being GG, okay, that we now use section GG as the basis for the functional score. But the other characteristics are basically the same. The other main difference here is that we've now collapsed a lot of the categories together. So there are now 23 nursing groups, I believe, as opposed to the existing 46. So, but again, the nursing component functions basically the same. So you have patient A receiving dialysis services with a nursing function score of 7, and therefore they fall into group LBC1. Patient B has septicemia, a nursing function score of 7, and is exhibiting signs of depression, and therefore would fall into group HBC2. Okay, so again, all of these various characteristics that we're using, okay, are all patient-driven characteristics that focus on the patient rather than on service utilization. That is the main theme of PDPM, is to focus on the patient and not on service utilization. So now that we've talked about sort of generally what PDPM involves, okay, and how a patient gets classified under PDPM, we'll talk a little bit more about some of the other things that are changing under PDPM. I don't like to toot my own horn or in any sort of way, but I think that I think we can all agree that since the inception of the SNF PPS, this is probably the single largest change that has occurred. Okay, we've seen RUG-3 transition to RUG-4. Obviously, that was a big change. Okay, but the change that we're talking about now is an entire change of dynamic and a change of emphasis. And we'll talk more about sort of some of those changes in just a moment. Okay, but this is a pretty significant and massive change in the overarching payment system. And understanding what those differences are is very important in terms of your success under the new model. So the first thing that we look at that's changed is in terms of patient classification data. So I've been saying a lot about the data that we use to classify patients. I've already made references to things like the therapy minutes that a person receives versus all the various characteristics that I just outlined related to PDPM classification. What is that? Sorry to the people on the line, there's this weird buzzing and it sounds like a giant bee about to drop out of the sky. Anyway, so RUG-4 and PDPM, both use the MDS. Okay, we have not changed the MDS. It is not the MDS 4.0 as some people have chosen to describe it. It is still the MDS 3.0, and it is the same MDS that we currently use to classify patients. So everything about that is basically the same. The main difference, however, is that under RUG 4, for over 90% of the days, we only use those two criteria. And this is the thing that always shocks me, is that walking into a facility, and many of you have actually been very gracious to allow me into your facility, and I walk into a facility, and the thing that always strikes me is being able to look at the patients that are in a therapy gym and just say, are you, maybe RV, are you? It's weird that I can say that, or if I just talk to a patient and I say, how you doing? How much therapy you've been getting over the past week? And, or talk to the therapist and say, how much therapy has this person been getting? And based on those answers, I don't have to know anything about them. I don't know their name. I don't know why they're there, which again, seems pretty important. I don't know what kinds of comorbidities that person has. I don't know anything else about the person other than how much therapy did you get this past week, and generally, how is your function? Okay, generally, how are you functioning? Based on those two factors alone, I can tell you what we're paying for over 90% of the days, and that just seems wrong. Okay, that's the inherent problem in the current system that PDPM is intended to address. PDPM, for every single day that we pay for, uses a wide variety of patient-driven and stakeholder-vetted characteristics. And when I say stakeholder-vetted, there were 4 TEPs, there was an advanced notice of proposed rulemaking, there was a proposed rule. We tried to get as much information from you guys as possible. So we feel very good about how collaborative this process was, and all of you have contributed a lot to this. So really, this is all of our system and not just CMS's system. Sorry, that was my emotional moment for a day. So for every day billed under PDPM, we are using this wide variety of patient-driven characteristics. Okay? It's not just therapy for some and not just non-therapy for others. Okay? And we'll talk a little bit more about that in just a moment. But it's using all of these characteristics for every single day. Okay? So again, primary diagnosis, comorbidities, their functional status, their nutrition and swallowing needs, all of these various characteristics that have wide breadth in terms of the things that they cover, but all related to that particular patient that you're looking at. The variable per diem is also an entirely new thing under the SNP PPS. It's not an entirely new thing under Medicare. It actually does exist in other Medicare payment systems, but it's entirely new for the SNP PPS. Now, as I mentioned before, the SNP PPS must be a per diem system per the Social Security Act, but that it doesn't need to be a constant per diem rate, because that constant per diem rate does not allocate sufficient monies when those costs are being incurred. And we don't want someone not being admitted to the door because of a concern that they require an expensive drug, and that if the person, let's say, discharges after a few days on a constant per diem rate, it's very unlikely you're going to get reimbursed appropriately for the costs incurred. And so as a result, the facility might be a little bit wary about taking that patient in. By front-loading the NTA costs, by having the costs allocated and paid when those costs are incurred, it encourages more adoption and more admission of those types of patients that you might be wary to take due to the reasonable expectation that that person might discharge and therefore you might not be properly reimbursed. Here's the schedule that we use for the PT-OT component as well as the NTA component. As I mentioned, the PT component and the OT component follow a pretty steady decline, starting at an adjustment factor of 1, which is to say that there is no adjustment for the first 20 days. And then beginning on day 21 and every week thereafter, there's a 2% decline. So it's pretty predictable decline over time. The NTA component, as I mentioned, is front-loaded. So there's an adjustment factor of 3, that is 3 times the normal rate for those first 3 days. Okay? And that's because, as we've seen, okay, drug costs are, and if you've heard me talk about this in the past, drug costs are not incurred in the same way as other kinds of costs. Okay? When you go to the pharmacy, you get a 30, 60-day, 90-day supply of drugs. You don't buy drugs on a daily basis. Okay? So by front-loading the costs, it ensures that you get properly reimbursed for those drug costs, and then you're able to dispense that to that patient over time, and that patient's able to get the care that they need. For days 4 through 100, it's an adjustment factor of 1. Now, there is an inherent risk associated with this that we'll talk about as far as that NTA schedule. And we'll talk about that when we get to discussions of the interrupted stay policy. But for now, let's talk about the emphasis of care and how that changes between RUG 4 and PDPM. One of the things that I've always had an issue with is I sort of have issues with any false dichotomies. But in particular, I think that there is an immense false dichotomy that exists currently within the SNF PPS, and that is this bifurcation between therapy and non-therapy patients. As if any patient that walks in your door just has one of those and not both for every patient that you see. Okay? There's very few patients, I would say, that walk in and just say, I only have a therapy need, I'm fine everywhere else. Okay? Or I'm just, I need some skilled nursing care, but I wouldn't benefit from any PT, OT, or speech. Okay? That is just simply false. Okay? Your patients are not therapy and non-therapy, or not therapy or non-therapy. They are therapy and non-therapy. Okay? They suffer from both. And so as opposed to the current system that would separate them into those two groups, so you either get a therapy rug or you get a non-therapy rug, and we're only going to pay you for one of them, PDPM looks at all of those various needs, pays for them all separately. And so as a result, it eliminates that distinction and looks at everyone in terms of their therapy and non-therapy needs alike. In terms of how we pay for patients with HIV and AIDS, there is an adjustment factor that currently exists under the SNF PPS of about 128%, or it is 128%, on top of the per diem rate. And that is because the statute, and there was a law that required this, that basically said that due to the high increased cost for this subpopulation, we're going to add 128% to that per diem rate. But that adjustment only would exist until such time as CMS develops, or the Secretary develops, a way of paying for this population more accurately. And so under PDPM, we feel that we've done that. So as opposed to the 128% add-on for this population, we instead have two new aspects in terms of how we will pay for this population. The first is that there is an 18% add-on, okay, to their nursing component. So if you have their nursing component, you just multiply it by 1.18, you get their new nursing component for patients with HIV and AIDS. The second is on the NTA component. And that is that the NTA component, as I mentioned before, has various points associated with each condition. For AIDS, it's 8 points. Okay? It's the highest number of points you can get for any condition. Okay? It's the most costly condition that we have on our list of comorbidities. So if a person has this condition, it would be reported on the claim the same way it's reported now. Okay? And we'll talk a little bit more about that. But they would report it on the claim, and their NTA score would be adjusted to reflect the addition of these 8 points. They would get reclassified, and you would get the appropriate NTA score. Okay, but again, as opposed to the just 128% adjustment on their entire per diem, this adjustment targets those two areas that we found to be most correlated with increased costs for this population, and they were the NTA costs and the nursing costs. As under the current system, the way that this is reported is not on the MDS, but it's reported on the claim. There are various state laws that prevent this information from being reported on the MDS in some states, and therefore we couldn't use the MDS as the basis for this, so it's reported on the claim. So you'd report the appropriate code onto the SNF claim. That is when the pricer will take over and do its work in order to put the person into the appropriate group, give the appropriate nursing component rate, and then give the appropriate per diem rate for that patient. Okay, so again, in terms of that, and we'll talk about, when we get to the discussion of things that don't change, this is one of those things that does not change under the current system, is in terms of how you are to report that a person has the condition and therefore how we pay for it. Some additional PDPM-related policy changes that I'm going to go through. The first relates to the MDS. Now, you've already heard a lot about changes that we're making in the MDS, and so I'm just going to sort of briefly go over this. Whoops. And the first main one is in terms of just the run of assessments that we have. So right now, you have scheduled assessments and unscheduled assessments, and not only on top of that, then we have to talk about combining assessments, and you have the assessment that's used for payment, and that payment might be taken over by something else. And then, well, what if I missed a COT, but then another assessment was done in the interim? Do I then? Yeah, there's a lot. Okay, and answering the questions is just as complicated as the questions that I get from you guys. Okay, you guys ask these amazing questions of us, and I look at it and I say, I don't know what we're doing. This is too much. Like, I had one question that was like, so I did a 14-day, but I set the 14 days so I would offset the COT, but then the person discharged, so I do a COT, and I'm like, okay, you know what? Can we just pay you at an appropriate rate and not have to have you do all of this? And the answer to that was yes, and the answer to that was PDPM. So PDPM eliminates the need for all of these different assessments, and eliminates the need for combining all these different assessments, and eliminates the need for assessments that were missed and another assessment was done in the interim, so it offset the pay. All of that's gone. Okay, PDPM assessment schedule is very, very simple. Okay, and we've taken a much more streamlined approach to all of this to make it easier for you guys, so you can actually focus more on the patient rather than focusing all the paperwork that we're having you guys do. Here's the assessment schedule under RUG 4. You all know it, you all love it. Okay, scheduled assessments, unscheduled assessments, in terms of when the ARD has to be set for, in terms of when they take over payment, you can see all of it here. Lots of words, lots of complexity. Here's the PDPM assessment schedule. 3 assessments. First, the 5-day assessment. It's the same 5-day you're doing now. It's exactly the same. There's a few additional items. Terry did a great job talking about that. Okay. Same basic assessment, though. The interim payment assessment. What am I about to say? It's optional. Thank you. I don't even have to say it anymore. It's great. The IPA, the interim payment assessment, is optional. When I say it is optional, I don't mean except in. No, there's no except, there's no but, there's no what about in this circumstance or scenario. There is no scenario. The IPA is an optional assessment. Okay? You are not going to get, I'm saying this out loud in public, you will not get cited because you didn't do an IPA. Okay? You can quote me. That's so dangerous. You can quote me on this, okay? You will not get cited for not having done an IPA. It is an optional assessment, entirely at the discretion of the provider. Now, I do know that some providers, okay, and some organizations have come up with rules for their providers for when they will choose to do an IPA. That is perfectly acceptable, okay? We are not advocating for that. We are not endorsing any of those various criteria, but I know some organizations have come up with criteria, and I think that those are all great. Okay, because they settle the question. There's no longer a question, should I do an IPA? Your organization has already come up with the criteria that you're going to use for your particular providers. And that's fine. But from CMS's perspective, it is, thank you. The PPS discharge assessment, again, same assessment that's currently being done. Few new items, okay, in relation to therapy, but generally the same assessment that's currently being done. So for the most part, it's the same assessments you're currently doing in terms of the 5-day and the PPS discharge and the IPA that is required. Sorry, that is optional. Sorry, still making a mistake myself. Interim payment assessment is optional. We're back to it. Sorry. I'm going to keep harping on this because every day I get a question that says, but in this scenario, should I do an IPA? And it's like, I don't know what to tell you. Eventually, I'm just going to say, yes, you're required to do it, and if you don't, we're going to cite you. So the optional assessment, it does not impact on the variable per diem schedule. Okay, you don't reset the variable per diem schedule if the IPA is done. That is an important thing to note about the IPA. The ARD is determined by the provider. Okay, there are no late IPAs. This is the other thing about the IPA. Okay, the IPA is optional, and in addition to that, you'll never have to bill default for an IPA because it was late or early. There actually are no early assessments under PDPM. That's actually kind of a nice thing. You can't have an early 5-day because that'd be weird. If you did it before the person got in the building, I suppose. And then there are no early IPAs because it's entirely optional. It's at your discretion to when you do it. And there's no early PPS discharges because A, they don't affect payment, and again, when they discharge. So it's pretty well set. So there is a payment impact. The payment impact is that it changes payment on the ARD. So as of the ARD of the IPA, that is when the IPA associated HIPS code would take over. And it would continue until the end of their Part A stay or until another IPA was done. Okay, fairly simple. The OSA is there's the optional state assessment. This was something that is used specifically for Medicaid programs and for states. If the question were asked to me of, you know, when should I do an OSA, the answer always from us is to talk to your state. Okay, so the states are going to be the ones that come up with the requirements for when OSAs should be done, and therefore you'd have to go back to your state to ask them when your particular providers in your particular state would have to do an OSA. But again, the OSA is specifically for generating those legacy HIPS codes that are necessary for Medicaid payment. Another thing that's changing under PDPM are limits in concurrent and group therapy. So you've probably heard this story before, and I apologize if you have, but I kind of enjoy telling it at this point. So we were meeting with an organization, and the question we knew that there was a likelihood that therapy as an overarching thing was going to change under PDPM. Okay, we knew, and more to the point, we knew it was going to decline. Okay, we'd heard this during rulemaking, we'd heard this in meetings with various provider groups. We knew that therapy was going to decline under PDPM. What we also knew was that it was likely that concurrent and group therapy, that non-individualized modes of therapy were also likely to increase under PDPM. We weren't exactly sure where to put the limit. Okay, we thought about it. We actually talked to, we talked about it in TEPS. We talked about it in a number of meetings. And during one of those meetings, the question was asked, if we set the limit on concurrent and group therapy to 25%, how much group therapy will your providers give? And the answer came back, 25%, without a moment's hesitation. Not, what about my patients? Not, hold on, I have to get back to you. It was 25%, obviously. Then the question was asked, well, what if we were to do 50% as the limit? How much group therapy would your providers give? Without a moment's hesitation, they said, we'll have to look at our specific patient population and get back to you. No, they didn't say anything like that. They said 50%. Again, we were actually quite shocked by just how blatant and blunt it was, that there was no hiding it, and that when I've asked about this, and when I've said to people during conferences and during other kinds of meetings, and I say that I was surprised that their answer was so quick, I've actually been told to my face, you're being naive. And that, again, is very shocking, okay? And not in a great way, okay? To be told that I'm being naive about the fact that patients and what they need would be driving care provision and not anything inherent in the payment system, that's a problem. So, because of that, we felt it was appropriate to put a limit on concurrent and group therapy. And we believe that the 25% limit is sufficient. Okay, we've looked at the data that currently exists. We see that concurrent and group therapy represents currently approximately 0.1% of all therapy that's being provided, or I should say that's being reported. And I'll leave that comment aside as far as the difference between reported and actual. But we do know that it's going to go up. And so we believe that 25% represents an appropriate limit that still allows for sufficient flexibility in terms of care provision. Concurrent therapy is defined here as one therapist with two patients doing different activities. You can tell that this presentation was drafted prior to the final rule going out. And that is because that definition of group therapy is no longer correct. The definition of group therapy is that it is one therapist working with 2 to 6 patients doing the same or similar activities. We have finalized that change. We now have a new definition of group therapy that is much more flexible than just having 4 patients. So thank you to all for your comments and helping us to finalize that policy. The limit that we have as compared to the current system, under Rug 4, we actually do have a limit on group therapy of 25%. Under PDPM, that limit is on both concurrent and group therapy. We look at, and it's not separate limits of 25% on each one, it is a combined limit on both concurrent and group therapy of 25%. Compliance with this limit will be monitored by those PPS discharge assessment items that Terry had mentioned earlier, okay, where we say how much therapy did that person receive over the course of their stay, based on the amount of therapy that person received over the course of their stay, and then we look at it by mode. If we see that concurrent and group therapy represent more than 25%, then you receive a warning message on your final validation report. To look at in terms of how we actually implement this limit, again, step 1, you have the total therapy minutes coming from those 0425 items that tell us, again, for each discipline, and that is also an important note here, is that the limit is done at the discipline level. So you have concurrent and group being combined, and it is done at the discipline level. So for PT, OT, and speech, we look at each one of those separately in terms of compliance with this limit. So you would look at each discipline, and you would add up the total therapy minutes, then you would add up the total concurrent and group therapy minutes. You then look at the ratio between those, and as long as that ratio is not greater than 0.25, then you are deemed to be compliant. If it exceeds 0.25, then you're deemed as being non-compliant. Here's an example here. I'm actually just going to go through one example for the sake of time. For PT, you have, again, the amount of individual concurrent and group that is being provided, 2,600 and 1,000 respectively. We look at the total number of minutes, which is 3,600 in step 1. Step 2, we look at just the total number of concurrent and group therapy minutes, which is 1,600. We look at the ratio between those, which is 0.44 or 44% of the therapy was provided in a concurrent or group setting. That 0.44 is greater than 0.25, so 44% is greater than 25%, and therefore is deemed as being non-compliant. So pretty simple in terms of the math. Just take the total number of therapy minutes, then look at the total concurrent and group minutes, and make sure it's not more than 25%. Now, I mentioned earlier when I was talking about the NTA schedule that there was an inherent incentive of vulnerability there that had to be addressed. And we're going to talk about it here in relation to the interrupted stay policy. The interrupted stay policy, again, is not something new to Medicare. It is new to the SNF PPS, but it's not new to Medicare. And it exists in other places. And those places where it exists because those payment systems utilize a model where a person you'd receive a payment, say, on a per discharge basis. Okay, so you receive a payment for that person's stay, and then that person discharges, and then they come back, let's say. Okay, and we see this in, say, the inpatient rehab facility prospective payment system. So let's say they're in an IRF, you receive the per discharge payment, that person leaves, and then they come back. Okay, there's an inherent incentive in that type of system to discharge and readmit patients to get new discharge payments, okay? To get more payments on top of that for that person's stay. To address that, and this again exists in the IRF PPS, it also exists in the inpatient hospital PPS, that in order to address that type of incentive, they introduce something called an interrupted stay policy, where if the person readmits within a certain window, then it's considered a continuation of the prior stay, and therefore you don't receive an additional per discharge payment. Now, we're obviously not a per discharge payment system. Okay, as I mentioned a number of times, we're a per diem system. So why do we have this? The reason we have it is specifically because of that schedule we had for the NTA component, for the variable per diem schedule. Because there's an inherent incentive very similar to the IRF PPS and similar to the inpatient PPS, where because of that high front load, there's an incentive for a provider to discharge a patient and then bring them back to try and re-up the NTA schedule, back up to day one, to get that high NTA payment for those first 3 days. To ensure that that wasn't happening, because I think we can all agree that frequent discharge and readmissions are in no way beneficial to the patient, so to try and address that potential incentive, we introduced the interrupted stay policy under the SNF PPS as well. The way that that is implemented under the SNF PPS, and again, we tried to mirror this as much as possible on the policy that exists in the IRF PPS and the inpatient PPS to ensure a little bit of consistency between settings. However, because the SNF is a very different setting as compared to pretty much every other setting, and we'll talk a little bit about why, we had to make it slightly different than those other two. So here, it follows the same basic logic though, which is that if a patient is discharged from their Part A stay, and then they are readmitted to their Part A stay during what we refer to as an interruption window, then it is considered a continuation of the prior stay. If it's a continuation of the prior stay, it really has two impacts. First is that the variable per diem schedule continues from the point just prior to discharge, and you don't have to do a 5-day assessment. You can just continue on with the HIPS code you were using prior to the discharge. Now, in terms of the interruption window, and this is something we've actually recently clarified to help people to understand how this interruption window works. And when I say before that the SNF is different than every other setting, here's the sense in which they are. If you're in an IRF, and you leave the Part A stay in the IRF, you have left the IRF. You're not staying in the IRF on a long-term care IRF stay. As compared to the SNF, okay, as compared to the nursing home, where you could have a person that comes in under Medicaid, under private pay, they're a long-term care patient. They go out to the hospital for a few days, and then they come back under Medicare Part A, and then after the Medicare Part A stay ends, they stay in the facility back under their long-term care stay. Or they're a person who comes in from the community, okay, they have a qualifying hospital stay, they come into the SNF, they receive the care that they need, and they go back home. Those are two very different kinds of patients, and there's actually two different kinds of impacts for those patients. For the first patient, okay, where they stay in the facility, that last day of Part A is still a covered Part A day. Okay, we still pay for that last day that they're in the facility when they transition over to the long-term care side. If that person discharges from the building, then that last day that they're in the building is not a covered Part A day. And so in terms of trying to understand when the interruption window begins and ends, we felt that we had to add some clarification here because, again, even though we were trying to mirror this on the other settings, the SNF setting is very different. And I'll say harder. I'll stay out there and say harder, but I work for them, so I think it's harder. The interruption window begins on the first non-covered day following a Part A covered SNF stay. Okay, so again, if that person stays in the building and goes to long-term care, then that first non-covered day is the day following their Part A stay. Okay, the first day that they transition over to long-term care. If they are someone who discharges from the building, then that first non-covered day is the day that they discharge from the building. Okay, so understanding what is that first non-covered day is important in terms of understanding when the interruption window begins. So the interruption window begins on that first non-covered day, ends on 11:59 p.m. on the third consecutive non-covered day. Okay, and again, to note that those Ds may be different in terms of what is that first non-covered day may be different for different types of patients. Okay. There we go. Sorry. So as I mentioned before, the interrupted stay has impacts on two aspects of their payment. First is that the assessment schedule continues from the point just prior to discharge. You don't have to do a new 5-day. You could do an IPA at your discretion as an optional assessment, but it is not required. And then the variable per diem schedule continues from the point just prior to discharge. So if the person is readmitted to the same SNF within that interruption window, then it's continuation of the prior stay, which means you don't go back to day one of the variable per diem schedule. If the patient is discharged from the SNF and is readmitted outside of the interruption window, or if they're admitted to a different SNF, then it's the same as the current system. It's an entirely new stay. Variable per diem goes back to day one. Assessment schedule goes back to day one. Everything else is the same. And as I mentioned here, and as I've been talking about in terms of those two different kinds of patients, this is not only applicable in terms of if they go home or if they go out to the hospital or something like that. It applies even if they're still in your building. Okay, if they're off of Part A and they come back to Part A within that 3-day interruption window, then it is considered an interrupted stay. Okay, so it's not just for people who leave the building. We have some examples here. Okay, Terry already went over a number of examples in terms of the interrupted stay. We'll go over a couple here. So you have the first one where a patient is admitted on November 7th, they're admitted to the SNF, they're admitted to the hospital on November 20th, returned to the same SNF on November 25th. Here, it would be considered a new stay. Why? Because they're being readmitted to the same SNF, but outside the 3-day interruption window. So it's a new stay, resets the variable per diem back to day one, and you have to begin the stay with a new 5-day assessment. Example 2, they're admitted to the SNF on 11/7, admitted to the hospital on 11/20, they're admitted to a different SNF on 11/22. So here, they're being readmitted back to Part A during the interruption window, but it's to a different SNF. And therefore, again, it's considered to be a new stay. Last example where we have a patient that is admitted to the SNF on 11/7, they're discharged from the hospital, discharged to the hospital on 11/20, readmitted back to the same SNF on 11/22. Here, they fulfill both of those criteria. They're admitted back to the same SNF for Part A. It should say admitted for Part A, but they're admitted, it says SNF. So they're admitted back to the SNF for Part A on 11/22. That's still within the interruption window, and therefore, this is considered a continuation of the prior stay. That means that the assessment schedule continues from the point prior to discharge, which means that no PPS assessments are required, but again, IPA could be done as an optional assessment. And the variable per diem continues from day 14, which is the day that that person had gone out in terms of their Part A stay. There's another example. We're going to skip over that for now. HIPS codes also changed significantly as a result of PDPM, because the current HIPS code looks at just that those first 3 characters are just the RUG code. Okay, RUB, PA1, whatever the RUG code is, that's the first 3 characters. Last 2 characters are an assessment indicator. It just tells us what assessment was being used. And as you can imagine, there's a lot of assessment indicators because there's the 5-day, the 14, 30, 60, 90, there's COT, there's, if you had a COT combined, there's a lot of them. So you have a lot of different HIPS codes under RUG 4, but they all start with, and they all have this basic algorithm of RUG code plus AI. PDPM, because we don't have a single RUG code, each of those first 4 characters is doing a little bit of extra work. And so the first character tells us what the PT and OT component is for that particular patient. Second character is their SLP component. Third character is nursing. Fourth character is NTA. And that 5th character is the AI code, of which I think there are only 2. So, but each of those first 4 characters is doing a lot of extra work. Okay, so we have a map in our rule this past year and last year as well that shows that if they're in a certain group, that it translates to this HIPS code character. Okay, so if they're in, say, group TA, which is the PT-OT group A, then the first character would be an A. If they're in PT group D, first character is a D. Okay, so it's a pretty simple translation. The only difficult one is nursing, and again, we have a nice map in our rules that shows the translation from the nursing group back to the HIPS character. In terms of default billing, under the current system, there is a default rate. Under the new system, there is also a default rate. Okay, that default rate represents the lowest possible per diem rate. And I think in our rule, either last year or this year, we actually laid out exactly what that default rate was. But the default rate, again, represents the lowest per diem rate. Under the current system, the default code is AAA00. Under PDPM, the default code is ZZZZZ, because quite frankly, if you get the default code under PDPM, you were asleep at the wheel. So that's why we did this. Medical review and data monitoring. Now, you might say, okay, well, that's going to be changing pretty significantly under PDPM. And the answer to that is yes, that it is going to change, but the importance of it, the fact of its occurrence doesn't change, okay, under PDPM. But the things that we look at in terms of medical review and data monitoring do change significantly under PDPM. Because under RUG 4, the main thing that we're looking at in terms of data monitoring and medical review is therapy. That's where the money is going to. That's where our review entities are going to go. Okay, so the main thing that we're looking at is in terms of therapy, looking at those facilities that have high RU billing, that is disproportionate to their patient population, things like that. Okay, so the main focus is on therapy billing. PDPM, however, because it takes a much more holistic approach in terms of care, we also take a much more holistic approach in terms of data monitoring and ensuring program integrity. So all of the things that we're going to look at are still important under the current system and still should be reported accurately. But we do anticipate that reporting is going to change once PDPM is in place. And so the things that we're going to be looking at are a lot more varied than just looking at therapy. Okay? All the things that I mentioned earlier, as far as swallowing disorders, mechanically altered diets is probably a pretty key one that we're going to be looking at. Okay? We are going to be looking at therapy still, because obviously therapy is still very important under PDPM. So we will be looking to see, are there changes in therapy provision over time? Okay? But the main thing to take away from this for me is that even though we're looking at a wide breadth of other things under PDPM, okay, in terms of data monitoring, and I'm going to mention it a little bit later in terms of documentation, the documentation doesn't change under PDPM. You're supposed to be documenting it now, you'll be documenting it under PDPM. The main thing that for me, I think that, and providers have agreed with this, at least those that I've spoken with. I can take that, sorry. The thing that I think that I've taken away from it, though, is that under the current system, the thing that you're having to justify when a RAC review occurs is, yes, this person needed 725 minutes worth of therapy. And you have to be making sure you document every one of those minutes worth of therapy and ensuring that there is sufficient documentation to justify every one of those minutes worth of therapy. And that can get a little bit murky, okay? I think admittedly, that justifying how much therapy a person needs exactly is a murky issue. As compared to, did this person have a major joint replacement? That's pretty easy. Okay, I should be able to look at a medical record and see, yes, hip replacement, done. Okay, that's a pretty easy one to look for. So not only does that make it easier for our review entities in terms of the things that they're looking for, but it also makes it easier for the provider because it reduces risk by focusing our review on things that are much more concrete. So it's just, yes, this person had a hip replacement, here it is in the medical record, and it's properly documented. Yes, this person had a swallowing disorder, here's where it is, here's where it's documented. Okay, so the things that we're looking at are much more concrete issues, which I think mitigates a lot of the risk for providers that you guys have been feeling, especially when it comes to things like RAC reviews and MAC reviews and things like that. So as I said before, therapy services still very important in terms of our overall review strategy, but we are going to be looking at things in a much more comprehensive way. And when I say we're going to be looking at things in a much more comprehensive way, we look at things currently this way too, but we don't just look at things in terms of our national statistics. Okay, we look at things in terms of a national level, state level, regional level, and at the facility level. Okay, we do look at every single one of the 15,000 providers, and our contractor is very good at popping red flags on if a particular provider is showing something that is aberrant or anomalous. Okay, so if we start to see significant changes in care provision that don't seem to be correlated with changes in, or that in terms of maintenance of high quality outcomes, or don't seem to be correlated with changes in patient population, that will be something that we take a much more strong look at. Now, I think this is the last one in terms of things that are changing, and it's one that I actually enjoy talking about because it's a little bit of a unique one to talk about. The things that we've been talking about up till this point in terms of those things that are changing are pretty technical. Okay, the assessment schedule is changing. Okay, the HIPS code is changing. This one's not as technical, but I think it's just as important. So we have a variety of ways that we measure quality under the various programs that we have at CMS. Okay, and under SNF, we have the SNF Quality Reporting Program, the SNF Value-Based Purchasing Program, Nursing and Compare. We have other ways of doing that. And a big term that's been thrown around a lot over the past number of years is the idea of value-driven care. Okay, and I've talked a lot in the past about sort of what defines value. And I think fundamentally it comes down to a balance. Okay, that when you're talking about finding the best value for a TV, a car, any widget you can think of, it's not just about finding the most expensive one. Okay, and even if you find the best one, that one might actually end up being really, really expensive. Okay, so you don't want to find the most costly one, nor do you want to find the one with like the most stuff. You want to find a balance, okay, between cost and quality. That's what value is. So a high value and efficient provider is one that is able to achieve high quality outcomes at low cost. under RUG 4, the things that we measure in terms of quality and the things that we look at as incentivized in terms of payment are actually aligned in very interesting and potentially not so great ways. One of the best examples I've thought of in terms of illustrating that point is pressure ulcers. So right now, one of the things we measure for quality is pressure ulcers, okay, incidences of pressure ulcers. If a pressure ulcer occurs, it usually is an indication, or at least a potential indication, of poor quality care, okay, if we start to see pressure ulcers developing. Not sure how that happened. However, under the current system, a provider is incentivized to provide as much care as possible, to provide as much therapy as possible. If you're providing that person with 720 minutes worth of therapy, it's unlikely they're going to start developing pressure ulcers. So by chasing the payment incentive, a provider actually ends up getting the quality incentive as well. But that's not the balance. Okay? You're not actually counterbalancing quality and payment. So under PDPM, we've actually realigned the way in which payment and quality incentives work. Because under PDPM, as I mentioned earlier, there is an incentive, okay, and I think this shouldn't be shocking for anyone because it's been told to my face a number of times. The incentive under PDPM is to provide as little care as possible while maintaining high quality outcomes. Okay? I've basically been told that very few people, I shouldn't say no one, very few people are likely to receive 720 minutes worth of therapy under PDPM. Okay? There is no incentive to provide 720 minutes worth of therapy, certainly not to all of the group of patients that a provider has. So therapy is in decline, service utilization is likely to decline. Now, if your service utilization declines too much, suddenly you start to see increases in instances of pain, increased incidence of pressure ulcers, okay, increased incidence of falls. All the things that we start to measure for quality start to now all of a sudden occur more frequently because of that decline in service utilization. So a provider is then put in a position of, I want to reduce service utilization for incentive reasons associated with payment, or to experiment with different models of care. But I want to ensure that I'm maintaining high quality outcomes. Striking that balance is the very definition of value-driven care. And so that's what we want to see. So this is one of those things that I think is important to note. And I'll mention it now. I'm probably going to mention it again in a few minutes. And I just mentioned it previously, that we are going to be looking at instances of service utilization decline. We are going to be monitoring for when therapy goes down and when group therapy goes up. Okay? And when those things occur, we will be red flagging that for ourselves. But does that mean that you're suddenly going to get a RAC review because your therapy went down? And the answer to that is no. Because that factor is taken into consideration with a whole lot of other factors, such as, was the facility maintaining high quality outcomes for their patients? And if we see that you're just experimenting with different models of care, you're trying a little bit more group therapy, trying a little more concurrent therapy, maybe trying some co-treatment, different things like that, but still seeing high quality outcomes for your patients, that's going to be the thing that either draws our ire or not. Okay? If we see high quality outcomes, then that means that you're doing a good job. If we see negative outcomes along with service utilization decline, then that's going to be the thing that draws our attention. If we see negative outcomes and you maintain high service utilization, you're still going to draw our ire because the focus is on patient outcomes. That's the thing that we are focused on. Okay, so service utilization, all the monitoring that I'm talking about is all taken into consideration in terms of how is it benefiting the patient, not the facility. So we've been talking this whole time about the things that are changing under PDPM. Take a moment now to talk about some of the things that are not changing under PDPM, because it's actually quite a long list of things that are not changing as a result of PDPM. Various basic administrative processes in terms of you submit an assessment gets submitted, you have a HIPS code, the HIPS code goes on a claim gets submitted. All those basic administrative processes stay exactly the same. The way we calculate the wage index is exactly the same. Okay, the way the ABNs and NOMNICs work, student supervision policies, all these are examples of things that don't change as a result of PDPM. But there are three other main areas that I want to focus on in terms of things that don't change under the new system. And the first of which is what is covered under the SNF PPS. The SNF PPS covers skilled nursing care, skilled rehabilitation, and a variety of other goods and services that are all outlined in our various manuals. PDPM does not change in any sort of way what is covered under the SNF PPS. If it's covered as of September 30th, it's covered as of October 1st. Okay, so whatever is covered under the SNF PPS benefit is still covered through this new system change. In terms of why it is covered, or in terms of the criteria that we use for coverage, all of those stay exactly the same as well. It needs to be skilled services. They must be provided on a daily basis. They must be reasonable and necessary to the treatment of the individual's particular medical condition. All of these are the exact same criteria that we use today to determine whether or not services should be covered, and they're exactly the same criteria that we use under PDPM. What you should document does not change as a result of PDPM. The various documentations requirements that we have, many of them are outlined in section 30.2.2.1 of Chapter 8 of the Medicare Benefit Policy Manual, and they include such things as that skilled involvement was necessary for the treatment to be furnished safely and effectively, that again, the services be reasonable and necessary. There's a bunch of others, but the basic point is what you are required to document today is the same thing that you were required to document 47 days, 22 hours, however long from now. Okay, so whatever you're required to document today, you're required to document under PDPM. Now, that doesn't mean that we are not expecting that there is going to be changes in terms of reporting, because we do know that the various things that are related to payment are quite few under RUG 4 and change significantly and become much more wholesome under PDPM. And so we do expect that reporting is going to change. We do expect documentation is likely to change in the sense that there will be more of it. But you are required to document it now, and you're required to document it under the new system. So it's just important to ensure that all of those various elements that we use for payment, okay, and all the various things that are related to patient care are adequately documented based on our criteria. Now the last one, where I like to get on my big soapbox for a little bit, is what your patient needs. Because while PDPM makes a wide variety of changes in terms of patient care, okay, and in terms of patient classification, it does not change one bit what your patient needs, which is the only thing that should be driving patient care under any payment model that we would put out. Two good examples of this is that if your patient needs 720 minutes worth of therapy under RUG 4, then they need 720 minutes worth of therapy under PDPM. I know you're going to say that's naive. I know you're going to say there's no incentive to provide 720 minutes. And my answer to that is I never said anything about the payment system. The most important word in that sentence was need. If they need 720 minutes now, then they need it then. Now we can all agree that patients today are receiving 725 minutes worth of therapy today that don't need it. Okay, they could probably benefit or probably only need less. I get that. That is why the important word here is need. If they need it now, they need it then. If they are not clinically indicated for group therapy, if they would not benefit from group therapy under the current model, they won't benefit from it under PDPM. Okay, there is no difference, other than the definition of group therapy, there's no difference between RUG 4 and PDPM in terms of whether or not a patient needs group therapy. Okay, so that is the driving force here behind your care decisions, is what does that patient need? This is going to be obviously a major component of our review strategy, is in monitoring for changes in utilization of various types of services. Another one that I haven't mentioned yet is mechanically altered diets. If they don't need one, don't put them on one. Like, that should be obvious, but I guarantee there's someone out there saying, okay. Like, don't do that. They don't like it. I've made those diets. They don't want them, so don't do that. Anomalies in comorbidity coding. Someone actually asked me before what that would mean. It means that if I look in Section I now and I see 0 diagnoses for a patient on September 30th, and then come October 1st, suddenly this person has 15 comorbidities that I would never mention before. That's an anomaly. That's something where I'm going to look at and say, what happened to this patient over the last day? Something bad happened, clearly. They developed diabetes, and all kinds of, now they have pancreatitis, they have COPD suddenly, okay? Those conditions don't all of a sudden pop up, okay? It's because it wasn't being reported currently, because it wasn't related to payment, and it is related to payment under the new system. We get that. So it is something that we're expecting, but those are going to be the kinds of things that we are looking out for. And if we see those significant shifts taken into consideration along with patient outcomes, that will be something that draws our scrutiny or not. Running a little bit short on time, so I want to try and get quickly through some of the last few slides here relating to transition and in terms of Medicaid. In terms of the transition from RUG 4 to PDPM, it is a hard transition. Okay, there is no glide path, there is no two systems running concurrently. We actually considered that for a short time in terms of running both of them concurrently for a year. No one wanted that, including us, and the MACs hated it. So there is no transition. There is simply, you're on RUG 4 on September 30th, and you're on PDPM October 1st. Now, in order to actually do that, we're going to look at different kinds of patients. So in order to receive a RUG-4 HIPS code that can be billed prior to October 1st, you have to make sure you have an assessment that has an ARD set for September 30th or prior. If it's set for October 1st or later, you're not getting a RUG-4 HIPS code. Okay, you're getting a PDPM HIPS code, which means in order to get that RUG-4 HIPS code that you need for billing us for Medicare, you need to have an assessment with an ARD September 30th or prior. Now, if a patient was admitted in those last few days of September, the provider has to still do an assessment with an ARD that's on or prior to September 30th in order to receive that RUG-4 HIPS code. So if they were admitted on September 28th, you can't wait until October 1st to do that a 5-day assessment. Okay, you still need an assessment with an ARD that's September 30th or prior. Okay, now that being said, you still have the usual 14-day completion window for that. You don't have to have it submitted by October 1st. It just needs to have the ARD set for September 30th or prior. If a patient was admitted prior to October 1st, and these are the transition patients, okay, if a person was admitted prior to October 1st and their stay continues beyond that transition point, here's where I'm going to go back on something I said just this one time. In order to bill for that person, you have to do an assessment that has an ARD that is between October 1 and October 7. And that assessment is the only required IPA. It's the only one. I know I said it was optional, and it generally is, and this is the only one. So there's what we refer to as a transitional IPA, so I'm not entirely a liar. So there's a transitional IPA, it's a different thing. And the transitional IPA has to have an ARD set for between October 1 and October 7. That will produce the PDPM HIPS code that you need to be billing as of October 1st. October 1st is considered day 1 of the variable per diem schedule. Even if that person's been in the facility since, for 30 days prior, day 1 of the variable per diem schedule is still October 1. Okay, so that's the HIPS code that you would bill as of October 1st. If a transitional IPA has an ARD set for after October 7th, it's considered late. The appropriate late penalty would apply. You'd get the at the sleep at the wheel ZZZZ default code. Now, if a patient stay begins on or after October 1, they're a PDPM patient. Start with the 5-day, you're off and running with exactly the same kind of thing that you're going to see for all of your patients begin October 1. Okay, so those are the easy ones. But for those transition patients, the ones that move over that gap between September 30th and October 1, that's where you need to be doing those transitional IPAs. Last topic is to talk about PDPM and Medicaid. So while this was designed as a Medicare payment system, obviously there are relationships and interplay between Medicare and Medicaid payment. And there are two main areas that we had to consider. The first is the upper payment limit, or UPL calculation, and the second one is case mix determinations, or really just how Medicaid pays for their patients. In terms of UPL, this is something that's a limit on how certain state Medicaid programs pay their providers. PDPM, because it changes the way in which we pay for SNF services, it does have an impact on how UPL calculations are conducted. And this is something that states are already engaged in looking at and have already been making a lot of headway in terms of understanding how UPL calculations would be affected. For any questions on that, there is a website that we actually give at the end, or a mailbox we give at the end for any questions related to UPL. But that's something that the states are already working through. The other side of this, however, is in terms of payment classification for Medicaid patients. Because right now, I can't remember exactly how many states it is, but it's more than half of states use some form of RUG version for their Medicaid patients. And we've seen some states that are still on RUG 3, some are on RUG 4, and there's actually different versions of RUG 3 and RUG 4 that they use. Under PDPM, since we've eliminated all the various assessments, we've eliminated a lot of ways in which states would be getting information from us as far as these legacy HIPS codes. So to ensure that states are still able to receive that information, we introduced the OSA. Okay, the OSA is intended to fill that gap of assessments so that, let's say a state were to say, we still want all of the COTs and things like that, for all of your patients, you'd be able to use the OSA to capture that information. Or we still want 14, 30, 60, 90-day assessments. Okay, let's say they follow just the scheduled assessment windows. You have the OSA. The OSA would be able to fill that gap. Okay, but here, the most important thing to understand is that the information on this is going to be coming from your states. The states are going to be the ones that dictate when an OSA would be completed and when not. Okay, they might just rely on OBRA assessments. They might just rely on 5-day assessments. It's entirely at the discretion of the state. But we do understand and appreciate the fact that there was an impact on states from this transition. So any technical support, okay, or the technical support we're providing for these legacy payment models, we actually said at one point that we were going to stop that after a year. Okay, we've actually since said that we will continue to support the OSA for a longer period of time. to allow states to collect the information that they need to consider a transition to PDPM if they deem so that's warranted. Last slide is just some resources that we have in relation to PDPM. We have the PDPM website, has a whole listing of different materials on it that everyone can use, fact sheets. We're actually going to try and get this presentation uploaded to that site as well. Various other things related to PDPM. For any questions that you have related to PDPM, there is a mailbox there. I will apologize now because I know that a number of you have asked questions to the PDPM mailbox and are waiting for responses. Unfortunately, we have an internal process that we now have to go through to get all these responses vetted. That takes a little bit longer. We are trying to shake everything loose out of that, but it is taking a little bit longer to get responses out of that mailbox, and so I apologize for that. And then the last one is OSA questions. There is an OSA mailbox there, but the OSA questions really should be directed to your state at this point. Okay, so I actually wouldn't even use this mailbox. I would actually just say, go to your state for any OSA-related questions. And with that, these are the lessons that we've talked about, and there's a minute left, so I don't know if we want to try and get some questions in. I like doing questions. I apologize, I need to leave more time. Hold on, I don't know where Bridget went. Oh.
I'm right here. So can we bring that slide up to look at the top questions?
Oh, cool. All right, so we'll take a look at some of these, and then hopefully I'll have a moment to take a question from the crowd. So the first question, so SNF QRP 59.5 items increases administrative burden. Yes, the number of assessments are less, but NAC role is evolving, but administrative owners are not considering. We're still hearing MDS positions are being reduced. Any way to spread that message to leadership? You've spread it. Well done. We have that message, and we appreciate it, and we will pass it along to our leadership. Will the significant change of condition assessment continue to affect reimbursement under PDPM? The answer to that is no. It will not. The IPA can be done if there's a classification change. Does classification change mean one change in one of the 5 component HIPS codes? Right, yes. It means that if, let's say, their primary diagnosis changes or their functional score changes or they develop a new comorbidity, whatever changes their PDPM HIPS code, if you want to do an IPA to capture that, then do it. Again, it's optional. You don't have to do it if there's a HIPS code change, but you can. Does CMS have any tools, index cheat sheet? I'm not sure I like that term. A regulatory administrative rule that indicated under PDPM for ADR audit claims. I'm not exactly sure what that means. I think if I am understanding it right, the tools that we have are the various tools that we have on the PDPM website. So this presentation, I would say reading the rules is important. All those things I think will be helpful in terms of understanding the things that might come under an audit and what needs to be justified. So with that, unfortunately, I think we're out of time. So thank you all. I appreciate it. I'll be around for questions.